Every year, many people receive antibiotics that they don't need, or they take them longer than necessary. You might think this isn't really a problem. After all, many antibiotics are cheap, and they have relatively mild side effects. But the more we use antibiotics, the more opportunities we create for bacteria to evolve immunity to those therapeutics, making antibiotics so ineffective that otherwise common and treatable infections become serious or even deadly. So, who's responsible for making sure antibiotics are used only when necessary and only as long as necessary? In a short commentary in the American Journal of Bioethics, I argue that it is not just doctors that have duties to minimize and shorten antibiotic courses. If recent arguments are any indication, anyone who communicates about, studies, or reviews antibiotic decisions may have similar obligations. In this episode, I'll lay out the argument and its implications for health systems. As always, you can find free copies of my papers on my website, byrdnick.com/CV under publications. When selecting an affiliate partner for this episode, Homestyler reached out, but their website's products were missing so many details that I was not comfortable recommending them. So instead, I'm going to mention that I have been using PDF Expert for about a decade. I'll be using it to read this article today. And I do that because its interface, to me, is more attractive than like Adobe products. It's often cheaper. You can find out more at the link in the description. You can find me on all the social networks, and you can ask questions on my website or in your podcast review. But for now, on to the commentary. The patient and pharmacy sides of shorter is better antibiotic stewardship. Shorter is better arguments conclude that clinicians are often ethically required to prescribe shorter antibiotic courses than they currently do, and depending on future evidence, shorter than current guidelines recommend. I agree. Nonetheless, shorter is better defendants admit that antibiotic courses may be longer than required to cure the patient due to factors besides clinicians' due diligence. Indeed, the shorter is better obligation is not implemented in a social vacuum. Patients often enter clinical encounters expecting antibiotics, interpreting non-prescription as under-treatment, and reporting their dissatisfaction with healthcare encounters accordingly. I will argue that so long as patients' understanding and expectations shape antibiotic prescribing, then shorter is better arguments imply duties not only for clinicians, but for any health professionals involved in relevant patient-facing communications and prescriptions, both before and after clinical encounters. Arguments. The clinician side of the shorter is better conclusion is well supported by a recent argument from Johnson and colleagues. Premise 1. Longer antibiotic courses often produce additional harms without additional benefits. Premise 2. Health professionals ought to reduce avoidable harms to patients when doing so is feasible within their professional role. Premise 3. Current antibiotic courses frequently expose patients to such avoidable harms. Conclusion 1. Clinicians are often required to prescribe shorter than status quo antibiotic courses. Notice how easily those premises generate duties for other personnel in health systems as soon as we consider a broader body of evidence about antibiotic stewardship initiatives. Premise 4. Patient expectations and understanding can contribute to harmful antibiotic overtreatment. Premise 5. Health system communications and audits can improve antibiotic decisions. Conclusion 2. Health system personnel working on both sides of clinical encounters, both before and after, have duties related to reducing antibiotic overtreatment. This argument extension is simple. If antibiotic prescribing can be changed through both the pre-visit and post-visit sides of clinical encounters, then shorter than status quo prescribing entails obligations not just for clinicians, but for any health system personnel working on patient-facing communication, pharmacy review, etc. After all, patient mindsets are formed long before they visit a clinic, and prescriptions are often reviewed after a clinician orders them. consider some relevant evidence and upshots. Evidence. Educational approaches to antibiotic stewardship have a mixed but instructive record. The Minimizing Antibiotic Resistance in Colorado project combined household and office-based patient education with physician feedback and guidelines. The program did not randomize, but it observed a large reduction in antibiotic prescribing for adult acute bronchitis in the intervention practices compared with control practices. Online decision experiments suggest that information about diagnosis and resistance from a clinician could improve patients' expectations about antibiotics. That literature matters for shorter is better arguments because many barriers to shorter courses have less to do with clinics' role in antibiotic decisions than with patients. Clinicians may worry that shorter antibiotic courses may violate an expectation or request from the patient or their family, and perhaps relatedly, increase personal responsibility in the event of complication or litigation. And antibiotic stewardship initiatives need to target actual mechanisms, not just outcomes. So although patient-facing communications are not a substitute for clinicians' duties, patient outreach and other mechanisms may impact the probability that clinicians achieve their duties. So we've been running experiments to validate educational messages and graphics that could be used in existing pre-visit, peri-visit, and post-visit health communication systems. So far, we're finding that a stewardship-oriented infographic reduced a desire for antibiotics, increased recognition that an upper respiratory infection was probably not bacterial, and increased recognition that antibiotics were probably unnecessary. A brief text message reminder also increased interest in trying over-the-counter treatment before seeking antibiotics. We've not yet tested the impact on acceptance of shorter antibiotic courses, but the upshot remains relevant. Patients' antibiotic decisions can be improved via communication delivery systems that transcend and scale beyond scarce, one-to-one patient-clinician conversations, in-clinic or telehealth. Upshots. This system-level perspective can be overlooked if patient education or prescription is imagined as reliant solely on a clinician. Figure 1 depicts multiple junctions and roles within each healthcare cycle from which health systems can improve antibiotic stewardship. Patient-facing pre-visit materials and nudges can improve patient understanding, prevent unnecessary healthcare visits, and help clinicians achieve better antibiotic stewardship during the remaining visits. These inputs look, quote, beyond the dyad, end quote, of shared decision-making models to a broader set of processes, interest holders, and responsible parties. Indeed, the figure even suggests that antibiotic stewardship duties extend downstream of clinical encounters, such as when internal investigators review prescriptions before they are sent to be filled by pharmacies. This is why the patient and pharmacy sides of shorter is better should be framed as integral parts of antibiotic stewardship rather than optional add-ons or causally downstream problems for someone else to handle. Pre- and peri-visit patient-facing materials may not fully determine antibiotic course duration, especially for complicated infections, nor should they fully displace clinical judgment or patient-clinician encounters. But neither should antibiotic stewardship implementation burdens fall solely on scarce, expensive, and burned-out clinicians. If health systems already know that patient expectations predictably intensify over-treatment pressures, and if existing communication and review infrastructure can be slightly modified to reduce those pressures, then health systems have reason to run control trials of such patient communication and post-visit reviews. Health systems may even be ethically obligated to run those experiments. All right, so what do you think? Do people besides just doctors have ethical obligations to improve antibiotic decision-making? You can tag me on Blue Sky, Threads, Mastodon, or the legacy platforms if you want to engage. You can also leave me a review on your podcast player of choice. And if you have any questions that you want to send just privately, you can message me on my website, byrdnick.com/contact.
Bye.